there, so I think we're all good. Okay, so we can get started. This is the agenda for today. It's going from 12:04 to 2 p.m. And we'll be trying to keep a close eye on the time. So for our speakers, Megan or Callie, I think Callie actually will be messaging you in the chat with some time warnings. They'll DM you. So if you're able to look at the chat while you're presenting to see those time warnings, that would be great. If you're not, we won't worry about it. And then, yeah, in terms of other logistics, again, please just make sure you are muted unless you're asking a question. Please feel free to ask any questions in the chat as we move forward. And then also Megan Lida on our team will be sharing the links that are in this deck.
SAD for everybody.
So as we go through the deck, you'll see some things are hyperlinked. Megan will send you those links in the chat, but don't worry because we will be sending out the slides afterwards. And so you'll be able to click on all the hyperlinks that are in the slides afterwards. And then we'll also, in our follow-up email, all of the things we link to will actually be included directly in the follow-up email. So don't worry about any links if you don't want to, but do keep in mind if you want to check out anything that Megan puts in the chat. Okay, so we will get started and introduce ourselves. If you could actually introduce yourselves in the chat, that would be amazing. So your name, where you're calling from or on behalf of, so your hospital or your organization, and your role, if that is relevant. So to introduce us, hello, my name is Katie Breen. I'm the Director of Program Management and Evaluation for CPCQC. And I will be one of your project leads for this project. And then Valerie, I'll let her introduce herself really quickly.
Hi, I'm Val Garrison. I'm the Director of Initiatives and Engagement with CPCQC.
Thanks. So Val and I will be the main points of contact for you all. To email us with any documents or any questions, please feel free to use info@cpcqc.org so you don't have to remember which of us to email for what or our names even. That will, when emails get sent to our info address, it gets sent to all of us and then we can sort of triage from there. So, yeah. And I'm realizing when I look at this picture of myself, I haven't used a blow dryer since the pandemic began. So that's fun. So the teams represented today. I just want to, give a warm welcome to all of the hospitals that are participating today, that are participating in the Learning Collaborative. And then I know, not all of these hospitals have 100% decided yet exactly how they'll participate in the collaborative. Most will be doing QI, but some aren't quite ready for QI and will sort of be following along the collaborative. And that's fine. We welcome literally anyone to join anything that we do. But we're really excited for the breadth of hospitals we have. And to show you, this is where all those hospitals are in Colorado on a map. And so thank you for continuing to chat in your introductions in the chat and let us know which hospital you're from. And if your hospital isn't represented, then I'm sorry, but thanks for putting it in the chat. And then I also want to call out, we're really excited. Obviously we're the state's PQC and we mainly work with hospitals in our state, but we don't necessarily have to only work with hospitals in our state. And we have a couple of initiatives already that work with some neighboring states, and this one may be one of them. So I wanted to call out, obviously right here is Colorado, and then we also have some partners who may join us in Billings, Montana, and then also in Phoenix. So that's really exciting. And honestly, the more the merrier. We're happy to have states whose own PQCs aren't doing this particular bundle to join ours or to follow along the work. So this is a good chance to say, feel free to invite people to anything that we do, unless we say otherwise, but I don't really think that would ever be an issue. So yeah, we're really excited to have so many people on the call, and I know we were only on these maps looking at hospitals, and so many of you are all over the state, not necessarily working on hospitals, but working with us, and so we really appreciate that. No need to read this right now, but I also want to give a warm welcome to our expert faculty group. We have an amazing group of people, as you can see on this slide, that are advising this work, that, you know, we're meeting bi-weekly to discuss the work and plan it. And once we really get into the QI of things, you know, we'll be troubleshooting whatever issues come up for our hospital teams with this group. The group will be able to provide technical assistance, you know, if our hospital teams need anything that any of our expert faculty group members are really experts in or have done before, our hospital teams are welcome and encouraged to get together with these expert faculty group members and, you know, see how we can help, because we are all here to help you and to support this work. So Megan will be launching a poll now, so we can sort of get started and get to know who else is on the call. So please, if you don't see the poll in pop up, you should see it right now. But if it doesn't pop up for you, maybe look around for your windows and see if it's hidden behind something. But yeah, please take a second to complete that poll. And once we sort of hit a critical mass, we'll close it and look at the results and get to see who has joined us here today. And Megan, I'll let you decide when to close the poll whenever you feel like it's good.
Hello. Yes.
Can someone mute themselves? Like, we're hearing someone answering a phone call. So if everyone could please mute themselves, that would be fantastic. Thank you so much. Okay, let's close the poll and we can see who we have here today. So what is your profession? We have a lot of people from who are CNMs, OB-GYNs, or family med MDs, a lot of nurses as always. We love nurses. Social work and case management. We have a lot of nonprofit partners, state agencies, and then other. If you are one of those other people, feel free to explain in the chat if you want to, but no need. And again, if you could please make sure you're muted, that would be awesome. Number 2, if you work for a birthing facility, how many births do you manage per year? So most, well, I guess not most, yeah, 17%, 1 to 300, 300 to 600, 600 to 900. And then we have 5 hospitals that have 2,000 births or more, births per year, 2,000 or more births per year. So that's a high volume. Okay, I'm going to close that poll and move on. Oh, wait. Their results. Stop sharing. Okay. Great. So moving on. So we want to start off today by really centering ourselves in why we are doing this work and why it is so important, and especially the focus in Colorado, but of course the partnering states have similar issues to Colorado. So to help us with that, we have Bree Thumb here from CDPHE, and she has a presentation for us. And Bree, I will advance your slides whenever you say so.
Great. Thank you so much, Katie. So as some of you know, I'm a midwife by training, and I practice at Denver Health. I also spent 7 years doing addiction research, and I'm currently the lead abstractor for the Maternal Mortality Review Committee at the Colorado Department of Public Health and Environment. And through these 3 lenses, I've seen a real clear need for the investment in resources to address perinatal substance use for our Colorado families, and specifically to reduce maternal mortality. And we really need to commit the resources, and all of your time is the most valuable resource. So I'm just so grateful that all of you have committed to doing this work and committed to being here today. So just a thank you to start. Go ahead to the next slide. And I know many of you on the call have seen these numbers. I'm going to start by talking about maternal mortality. The other public health crisis confronting the United States. It's been on the rise for over a decade nationally, and Colorado's no exception. This graph is the pregnancy-associated mortality ratio for Colorado up through 2016, which is the most recently published data that we have. And the pregnancy-associated mortality rate, just to orient you to the numbers, is the number of deaths divided by the number of births multiplied by 100,000. So you can see here that it has been increasing and it's continuing to increase. Go ahead to the next slide, please. And so for the remainder of the time that I talk about maternal mortality, I'm going to focus on the deaths that occurred in Colorado between 2014 and 2016, which are our most recently published data about maternal mortality. And you can see here that the second leading singular cause of pregnancy-associated death in Colorado during that time period was drug overdose. 13.8% of deaths were caused by overdose. And in our previously reported data, which was 2008 through 2013, toxic levels of drugs were found in 28.3% of the pregnancy-associated but not related deaths. So this has been a problem in Colorado for well over a decade. Next slide, please. I don't want to get too in the weeds of how maternal mortality is analyzed and reported, but this graph shows the causes of pregnancy-related deaths between 2014 and 2016. And a pregnancy-related death, those are the deaths that the Maternal Mortality Review Committee determines are the result from a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy. So what this slide shows us is that the committee that, for those deaths that the committee determined were pregnancy related, 34.2% of those were from overdose, suicide, or homicide. And those numbers are too small to break down further, but what the real takeaway is that there are deaths from overdose that the Maternal Mortality Review Committee are determining are the direct result of pregnancy. An example of this would be a person who starts using drugs at a higher, using more drugs, using more because of the stresses of pregnancy that ultimately results in an overdose death. Go ahead to the next slide. Of all the data that I'm going to be presenting about maternal mortality, I think this is the most compelling. The Maternal Mortality Review Committee determines whether or not substance use contributed to each death. And this means that even if the death wasn't the direct result of an overdose, that substance use in some way contributed, for example, of a suicide death. So of all the deaths, whether or not the committee determined they were related to pregnancy or not, the committee determined that substance use contributed to 30 of the deaths and probably contributed to an additional 9 deaths, which is a full 41.5% of pregnancy-associated deaths for which substance use contributed. And of the pregnancy-related deaths, substance use did or probably contributed to 42.1% of those deaths. So it's playing a huge role in maternal mortality in Colorado. And my last 2 slides specifically about maternal mortality are about preventability. The Maternal Mortality Review Committee is tasked with determining whether or not a death is considered preventable. And it determined that over 3/4 of pregnancy-associated deaths were considered preventable. Go ahead to the next slide. And when we look at the 39 deaths, pregnancy-associated deaths for which substance use contributed, 92% of those were preventable deaths. So there is so much room for the work we're doing and improvement to be made. These are preventable deaths related to substance use. Go ahead. Thank you. So I want to switch now to a few other things that we know about perinatal substance use in Colorado. These next data are from the Pregnancy Risk Assessment Monitoring System, PRAMS, which is a population-based surveillance system that samples pregnant and postpartum people and pregnant in Colorado through the mail or the telephone surveys. And it's conducted both in Colorado and in states throughout the country. So you'll see some comparisons to national samples as well here. These data are from 2019, for which there were 1,101 people surveyed with a 59% response rate. And what we found was that 6.6% of those used opioids at some point during pregnancy. And of those 6.6 that did use opioids during pregnancy, 20.9, so around 1 in 5, reported that they some misuse of opioids during pregnancy. And then these next these two bar graphs at the bottom are about where people have accessed opioids. That 84.7% of the respondents said they'd gotten their opioids from a healthcare provider, which is slightly lower than the national sample. And I understand that these two graphs don't totally add up because that's kind of how the questions were worded, but around 9%, 8.8%, indicated that they had accessed opioids through a source other than a healthcare provider during their pregnancy. So to give you kind of a picture of people in Colorado and where they're accessing their opioids during that pregnancy and postpartum window. And then, thank you. And these are questions we asked about the reasons for using opioids during pregnancy. And 8 out of 10 respondents said they used it for pain purposes. And again, because of how the questions are asked, but that 13, it doesn't always tabulate to 100%, but 13.1% of those that used opioids during pregnancy reported that they had used them for a reason other than pain management. And then this is, these next couple points are about provider education about opioids. And of everybody that was surveyed, so whether or not they had reported using opioids or not, 41.3 reported that their healthcare provider had talked to them about how using prescription pain medication could affect their infant. And then 67.9 that's the percentage of those that reported using an opioid during pregnancy. So that's 6.6%. 67.9% of those reported that their healthcare provider had talked to them about how using opioids could affect their infant. So I found this number alarming because of those who are taking opioids during pregnancy, there's a large percentage who had not been talked to by their healthcare provider about the potential effects of those opioids. And I think unpacking these numbers a little bit more, what we don't know from this is, like, of the people who were taking opioids who had not been talked to about how those opioids could affect their infant and their pregnancy, we don't know whether or not the healthcare provider even knew that they were taking them. And this really speaks to that need for universal screening, and what we're all here to talk about today is the need for that universal screening so that healthcare providers know and so they can tailor their patient education accordingly. Go ahead to the next slide. And this is also about, thank you, got it, Callie. About educating our patients about opioids. And while the majority of the respondents did know that opioids, whether prescribed or not, posed a risk to their infants, 31.2% reported that they believe that opioids, if they were prescribed, were not harmful to infants. So that's a real window of opportunity for us and something that is addressed in the AIM bundle that we're here to talk about today. So I want to conclude with how the work that you're doing really fits perfectly into the framework of recommendations to reduce maternal mortality in Colorado. This framework was put forth by the Colorado Maternal Mortality Committee to the Colorado Legislature in July of 2020 as recommendations to reduce maternal mortality of any cause. You can see the overarching recommendation is the elimination of structural and interpersonal bias and discrimination in the delivery of services and supports needed by pregnant and postpartum people. And within that, under that umbrella, are 12 specific recommendations, which are actually in prioritized order, based on the level of how much they would impact maternal mortality. If you want to go to the final slide. So you'll see that numbers 2 and 3 of these prioritized recommendations are number two, integrate universal screening and connection to treatment for substance use disorders into maternity care. The Maternal Mortality Review Committee, based on their findings, determined this was the second most important priority to reduce maternal death. And then the third is to improve opioid prescribing practices. So really, this is specifically what you all you're here for today, and I thank you all for being here and to really take the reins on implementing these recommendations and really improving the well-being of pregnant people and their families in Colorado. Thank you so much.
Thank you, Bree. And I said this in the chat, we are doing really well on time, but if you could chat in any questions for Bree, and we'll make sure that we keep track of your questions and take care of them. But we do want to move on so we have enough time. So, Bree really set up why we're doing this work in Colorado. And so now I want to talk a little bit about how we in Colorado as a collaborative will be tackling this issue. So our shared vision for this collaborative is that we will all work together to reduce maternal deaths caused by accidental overdose and suicide in Colorado. So as you saw, those are the two leading causes of death that Bree discussed, that the MMRC found. And so that is what we're here to work on. We know that they're preventable, and we know that by doing this collaborative, we can help prevent them. So these are our Learning Collaborative goals. I'll cover the 3 goals. The first one is that by the end of this year, all of our participating hospital teams, 100%, will implement a universal evidence-based and patient-centered SBIRT protocol for addressing substance use and mental health for all patients admitted for birth. So that's really about the protocol and process implementation. Project goal number 2 is that 100% of patients admitted for birth are screened using a validated tool for substance use and maternal depression and anxiety. And number 3, as part of signing up for this project, we asked you to complete the SBIRT core components readiness assessment, and that spat out a score for you. And so our goal is that by the end of the year, the average score for all of our teams participating will increase by 29% relative to the pilot team's baseline average. And so that would mean the average would go from 17 to 22 for the whole cohort. So how are we going to get there? So this collaborative will really be based on the Institute for Healthcare Improvement, or IHI, their Breakthrough Series collaborative model. And what that model does is help us as a collaborative to work on knowledge sharing, education, targeted tests of change, and data collection in order to track our progress towards those goals. So this is the structure of the IHI Breakthrough Series learning model. You don't need to worry about this too much right now, but just so you understand where we are and where we're going, we've spent, the last couple of months talking to you and emailing you and bugging you, and that was sort of this section. And then now that we've had our kickoff today, we are in the pre-work period. Our first learning session will be on April 2nd. So everything we talk about today will really be about making sure that you understand what happens in the pre-work period and where we're going from here. And I won't spend too much time on this slide, but if you are curious about what all of those terms mean, and a lot of today will be about sort of defining these terms. The terms can be very jargony, and if you haven't been sitting in 10 hours of IHI meetings all the time, then they're new to people, and that's fine. So, if you want to read these slides later, you can just read about what the definition of the terms are. These are the key dates for the collaborative that are tied to each of those little boxes on the previous slides. I won't read this to you. You'll receive this in the slides after the call and in a couple of documents after the call, but just wanted to call out that these are the specific dates tied to those boxes in the diagram. So in participating, what you can expect from us is that we will provide quarterly learning sessions and monthly webinars. And on those monthly webinars, we're calling them coaching calls because there will be specific content covered in part of the call. And then a large portion of the call will be dedicated to discussion and sharing and, sharing any challenges you're having that other teams or the expert faculty group can help with. And then, of course, we'll be providing implementation guidance and support to help your teams design the protocols that work the best for you. We'll be providing rapid feedback. So all of the QI documents that we'll talk about later, all of the data, that the intention for all of those is that we can help you improve by helping you with rapid feedback. Data insights, similar to what I just said, we'll be able to compare your hospital against other hospitals in the collaborative in an anonymous way. And then we'll also be able to, again, anonymously compare your hospital's progress to nationwide other hospitals that are participating in this particular AIM bundle. So that is one of the main benefits of us being the implementers of AIM in Colorado, is that we do have access to the AIM data center. And so we can really compare what we're doing to what states implementing the same bundle are doing. So that's pretty cool. Clinical and improvement science education, of course, provider training, of course, and then public recognition as a maternal and infant care quality champion so that you can celebrate and showcase the work of your team. And then what we ask back from you is commitment to improvement, establishing that multidisciplinary team to help improve outcomes, active participation in all of our events and all of the pre-work, implementation. So actually implementing some of those tests of change during the action periods, which we'll talk about in a little bit. Data collection and reporting. So reporting your data to us by the last day of each month, and then providing feedback. So this is, always a work in progress. We always want to hear from you, and anything we can do to make your experience in the collaborative better or to help you with anything, we want to know. So with that being said, really quickly to orient us to, again, how we'll run this collaborative and what it's based in, and then also what the documents that Val will be talking about later. I want to talk about improvement science really quickly. So the science of improvement, it's actually an applied science with the goal of generating, learnings about what changes in which contexts produce improvement. So it emphasizes innovation, rapid cycle testing in the field, and then spread of the changes that end up turning out to be effective. So this is the IHI model for improvement. And again, don't worry too much about this because we're going to teach much more of this in learning session 1. But the model for improvement asks 3 questions. What are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in an improvement? And then we employ these plan, do, study, act cycles, or PDSA cycles, for small rapid cycle tests of change to, try to see what works. So that is sort of the framework that our work will be grounded in, and the framework that other states work on this is grounded in as well. And to give you an idea of what this improvement science and what all these methods look like in action, we're really excited to introduce Dr. Ann Borders from the Illinois Perinatal Quality Collaborative. And she's going to talk about the lessons learned from Illinois as they have been implementing this bundle, I believe, for the last 3 years and have done amazing work on it. So we're really inspired by Illinois and want you to be inspired too by their work. And so we will have Dr. Borders tell us about what they've been able to accomplish there.
Hello, can you hear me okay?
Yes.
Hey guys, so let me change my view a little bit so I can see, there we go, so I can see everybody. So my name is Ann Borders. I am a maternal fetal medicine physician and getting ready to take over call for the weekend as soon as I finish this talk. So deliver a lot of babies, take care of a lot of patients. And I'm also the executive director of the Illinois Perinatal Quality Collaborative and the obstetric lead. Today, I'd like to, in about 30 minutes, go through our initiative, the Mothers and Newborns Affected by Opioids Initiative, or MNO, is how our teams across Illinois talk about it. And I'm really excited to share what we've learned, because I'm hoping that by seeing what we have done and what we learned and what we realized over time we had to prioritize, and what our teams learned they had to prioritize in order to make improvement in terms of optimal care for moms and babies exposed with affected by opioids, it will help you all. Our project was specifically focused on opioids, and that was based on our Maternal Mortality Review Committee data. And I know you're doing it a little bit more broadly on substance use disorder, but the lessons learned and our goals will apply because I think even for our project, even though we focused on opioids, we were able to implement in a way that we didn't leave other substance use disorders behind. We just chose to focus it so that we could really measure and be very focused in our actionable strategies. But those strategies, when put in place for opioid use disorder, then had an impact to care for women with other substance use disorders as well. Move to the next slide, please. So I'm going to go briefly a little bit over the opioid epidemic, but you guys have seen a lot of that already, so that'll be just pretty quick. And I'll go through our aims and key strategies, and then go through our progress on the initiative so far and our data and outcomes so far, and then hopefully there'll be a little time for questions. Next slide. So the Illinois Perinatal Quality Collaborative, to get you guys a sense, we've been functioning for about 7 or 8 years now. We are a collaborative led by physicians and nurses, made up of hospital teams. We have lots of patient engagement and patients who serve on an advisory capacity. We work really closely with public health leaders and other stakeholders and community stakeholders around the state. We implement data-driven, evidence-based practices to improve maternal and infant outcomes in Illinois. We have an OB side and we have a neonatal side, and we work on some initiatives together and some separately. The MNO initiative we had was split up between both OB hospitals and neonatal hospitals, working in kind of parallel tracks. Overall, we've had about 118 hospitals involved in one or more of our initiatives. So we cover about 99% of Illinois births. And we have both an obstetric advisory work group made up of OB, MFM, midwife, nurses, patients that advise all the obstetric initiatives. And then we have a neonatal initiative as well, a neonatal advisory work group. And those work groups meet monthly and advise the work of all the initiatives. Next slide. Just want to show you where the MNO initiative falls in our other initiatives we've worked on. So like I said, we started in like 2014. The peach are our neonatal initiatives and the blue are our OB initiatives. So we worked on the MNO, the Mothers and Newborns Affected by Opioids, between 2018. We just ended the active phase of the initiative in December of 2020. We're now moving into this year is our kind of sustainability and helping teams to cross the finish line. So anyone who hasn't achieved the initiative aims. And we're getting ready to launch a birth equity initiative this summer, and we started a Promoting Vaginal Birth initiative in January. Next slide. So we're really driven by our maternal mortality review committee data as well in Illinois. We've had a shocking increase in overdose deaths maternal deaths related to opioids. Our pregnancy-associated deaths have increased tenfold. I think they doubled again 2 years ago from 2017 to 2018. So in 2016, there were 10 maternal deaths related to opioids. In 2017, there were 20, and I think it doubled again in 2018. And we compare that to deaths from postpartum hemorrhage, there were 6, and from hypertensive disorders of pregnancy, there were 6. So the overdose deaths in pregnancy and the postpartum period from opioids just far outshadows any other reason that a woman dies in pregnancy or the postpartum period. And our entire initiative is really moving to have the OB clinical team really recognize that when they have someone with substance use disorder, particularly opioid use disorder, they have a patient in front of them that is the highest risk of death of any patient that you're going to have on your labor and delivery, of any patient you're taking care of. So you should be putting them up there with patients who have complicated cardiac conditions, people that everyone's talking about and doing conferences about. Your patients with opioid use disorder are the patients that are going to die, most likely of any of the other risk factors that you take care of. And so they deserve all of our attention and really figuring out how to provide optimal OUD care during pregnancy and the postpartum period for every single patient. And that really became the focus of our initiative. Next slide. I think it's clear probably in Colorado, but certainly it's been clear in Illinois that we really see a continued skyrocketing of overdose deaths in the setting of the pandemic. So COVID has not slowed this as well at all. It's actually skyrocketed. So we continue to see an increasing number of deaths secondary to the pandemic. Next slide. I think it's really important that folks realize that this can happen to anyone. The wealthiest patients I've taken care of and the poorest patients I've taken care of, and soccer moms and nurses. I've taken care of patients from every single socioeconomic status who have horrible problems with opiate use disorder. No one sets out to have a problem with opiate use disorder. It's not a choice that someone makes. It's a horrible, horrible, chronic and life-threatening disease. And people need to really see this as a clinical and a life-threatening medical condition. And I think that's one of the challenges, is that many people really still see this as a social problem, as something that you need to call social work for, so that someone can talk to them about DCFS, that the baby can be looked at. And they're not seeing this as a life-threatening medical condition that needs optimal treatment. Next slide. It's really important to bring patient stories into this work. We spent a lot of time bringing patients' voices to the work that we've done. When we started this work, we set up patient focus groups of moms who'd had opioid use disorder with babies in the NICU with opioid-exposed newborns, and had them help us rework all of our patient-facing educational material, which was incredibly helpful. We have patients talk at every single one of our in-person meetings about their experience with opioid use disorder. It's important that people really understand patients beyond the opioid use disorder and beyond the addiction, and really think about where patients are in their lives and how interaction with the medical community during their pregnancy, when it's done correctly and patients get optimal care, can really set women on the road to recovery and save their lives and improve their pregnancy outcomes. We say this over and over again, that OUD is a life-threatening medical condition, and that linking women with OUD to treatment and services reduces overdose deaths for moms, improves pregnancy outcomes, increases the number of women who can parent their baby. So those 3 points are really our mantra. We use those over and over again when we're talking to clinical teams. They need to understand that by taking action, identifying these moms early in pregnancy and getting them linked to treatment and recovery treatment services, you're going to do those 3 things. You're going to reduce overdose deaths, you're going to improve pregnancy outcomes, and you increase the number of women who can parent their babies. Next slide. It's important that your providers and your teams understand that treatment works, and really think about this initiative around moving towards that idea of optimal opiate use disorder care. It is a chronic treatable brain disease, and it can be managed successfully by combining medications with comprehensive care and recovery support. Treatment enables those with OUD to regain control of their health and their lives. Next slide. And this is a really important component. I think this is one of the more important slides I'm showing you guys. And when you're trying to make the case and get buy-in from your obstetric providers and your nurses, this is so important because they often feel like they're going to throw up their hands. Well, what am I supposed to do? This patient makes poor choices. This patient has opiate use disorder. This patient uses drugs. They're making poor choices. They don't care about their pregnancy. So you're going to hear all that judgment, and you really have to push back against it and figure out how to move people towards empathy and towards seeing these patients as having this chronic life-threatening disease, and that there's a treatment that really reduces their adverse outcomes and reduces death. So this slide, the yellow are patients who were on medication-assisted treatments, so methadone or buprenorphine. The gray are those pregnant patients who are not on methadone or buprenorphine. So what you can see is that when you have patients on treatment in the orange, it cuts their risk of overdose in half. So these were overdose. It was overall, and then you look at the year prior to delivery, first, second, and third trimester, 0 to 3, 4 to 6, 7 to 9, and 10 to 12 months. And what you see is that postpartum, the risk of death just keeps going up. And we see the postpartum period as a particularly at-risk time for women with opioid use disorder. Many women cut down their usage during pregnancy. You can see that third trimester, second trimester, they really cut down their usage. So even women who weren't on MAT see that drop. It's because they often reduce the amount that they're using during pregnancy, particularly in that second and third trimester. Postpartum, many women lose access to their medication, lose access to support and resources, increasing stress, particularly if a baby has been taken away from them or have a baby in the NICU. And you start to see women reusing their old levels of opioids, and you see overdoses happening. So it's a particularly at-risk time period. And that's why it's so important that we identify these women early in pregnancy, we get them linked to medication treatment and to recovery treatment services, and we follow up with them quite closely in the postpartum period. Next slide. So we launched this initiative, Mothers and Newborns Affected by Opioids, with 107 hospitals. We had 101 OB hospitals and 88 neonatal hospitals teams, and we started in May of 2018. And our project basically is to have monthly webinars where teams shared with each other. So we do team talks, which teams share their current progress, their strategies. We do a lot of data review. So our teams all track structure measures, which I'll show you where they are in the systems changes that we're working on. And then we also look at process and outcome data. So we're looking at a lot of data. We're focusing on specific strategies, actionable strategies with each call. And then we get together twice in person, the way our collaborative works. So we get together in the spring for an all-day OB meeting, followed by an all-day neonatal meeting. And then in the fall, our teams get together. And we really work on strategies and do a lot of breakout sessions. The goal is for hospitals to learn from each other and to support each other, and then compare data so you can see how you're doing compared to everyone else. Next slide. So these were our goals. We're also very focused on very specific achievable aims. So each team knows whether they've achieved the initiative aims or not. And then we do a lot of rewarding with plaques and banners and other things as teams achieve these aims. So having teams achieve over 80% universal validated OUD screening, prenatal labor and delivery, over 70% of patients linked to medication-assisted treatment prenatally or before delivery discharge, over 70% of patients with OUD linked to behavioral health and recovery treatment services prenatally or before delivery discharge, over 70% of patients having a completed opioid use disorder clinical care checklist. This includes things like prescribing, counseling and prescribing Narcan, completing a hepatitis C screen, et cetera. And then making sure that patients are receiving education on OUD and NAS, or NOWS as we're now sometimes calling it. This is providing counseling materials, so those education materials I talked to you guys about that we created for patients, doing a neonatal pediatric consult, but in some way making sure that mom understands non-farm care and how she can be empowered to participate in her newborn's care, and really understanding what she can expect when she goes to the hospital. Next slide. We found really early on one of the most important things of this initiative is to communicate to the clinical team. They had the understanding of opioid use disorder was not sufficient, and I think most importantly, this idea that it wasn't the clinical team's responsibility, that this was an issue that we were screening moms. Really, the idea was we were screening moms to identify babies at risk, and we didn't think of the mom in front of us as being someone at risk. So we found out pretty quickly that we needed to do a campaign for education to really help people understand these key points. Opiate use disorder is an urgent obstetric issue. Opiate use disorder is a life-threatening chronic disease with life-saving treatment available, and reducing stigma improves outcomes. There are key steps OB providers need to take prenatally and on L&D to care for women with opiate use disorder, and that linking moms to MAT and recovery services reduces overdose deaths for moms, improves pregnancy outcomes, and increases the number of women who can parent their babies. So these messages became really important. We felt we couldn't do anything else if we didn't get buy-in on these issues. Doesn't matter if you implement systems changes on your labor and delivery in your prenatal care clinics. If people don't understand these issues, you will not improve care for your patients. Next slide. We worked pretty hard on this protocol. One of the things we found really quickly is that OB providers and nurses don't have a great understanding of what SBIRT is. Even though we spent a lot of time on this, when we had a learning session together, what we found is that everyone was looking for a way for someone else to do SBIRT because it was confusing to them. I wasn't trained. I don't know these initials SBIRT. What does this mean? I'm sure there's a social worker who can do this, or can't you call someone from drug treatment, or maybe psychology can do this. Can someone be linked to do SBIRT 2 weeks from now when the patient goes home? We had to break this down to say, SBIRT is, we stopped even using SBIRT because we really started talking about it as we need to universally screen the patients. You need to go in and talk to the patient and do a brief intervention. Then you need to link that mom to recovery treatment services. So this protocol was really helpful for us. Screen and document the positive result, provide an SBIRT risk assessment and brief counseling regarding the benefits of treatment, next steps for linking to care, activate care coordination or navigation to link women to MAT, behavioral health counseling recovery programs with warm handoffs and close follow-up, insert and complete the OUD clinical care checklist into the electronic medical record, making sure that patient gets a Hep C screen, making sure they get Narcan counseling and prescription, and then provide the patient the education regarding OUD and NAS and engaging in newborn care. So those are the handouts and the Peds neonatal consult. And we worked really hard on figuring out how do we activate this protocol every time for every screen positive mom. One of the challenges is that some hospitals, many hospitals, don't see patients with substance use disorder, abuse use disorder regularly, or many providers or nurses won't see these patients. So it's a little different than implementing a hypertension initiative where people are gonna see hypertension patients on their labor and delivery every day. This is something they're not gonna see as reliably. So I'll talk to you about some of the systems we've put in place to figure out how to activate these systems, even if you're at a hospital that doesn't see it very often. Because many of the women who die with opioid use disorder walk into those hospitals who are small community hospitals that don't see people with opioid use disorder often. They walk into big hospitals too, but people die from every sort of big or small hospital, and we had to have an ability to have these systems in place no matter where a woman shows up. Next slide. So these are the things we asked our teams to do. We had to use language that was very specific. So it's not good to speak in generalities when you're trying to get people to do quality improvement. You need to be very focused on specifically what you're asking them to do. Then you need to put the systems in place to do it. And then you need to get buy-in and education to tell them why they need to do it. And then you need to track the data with compliance to show that they did it. And if they're not doing it, you have to feed it back to them, or else people just don't change. Otherwise, you just have a lot of meetings where people talk about doing things. You might put some systems in place, but the culture doesn't change on your unit and the care doesn't change for the patients. So screening every pregnant patient with for opioid use disorder with a validated screening tool. I'm going to talk briefly about what that means to have a validated screening tool. We screen every patient prenatally and during the delivery admission. Assess readiness for patients who screen positive for medication-assisted treatment. Some people are now calling this medication-assisted recovery, so buprenorphine or methadone. So patients really understand the benefit of being on treatment, particularly for pregnant and postpartum patients. Link them to MAT and to recovery treatment services with warm handoffs and close follow-up. Provide naloxone or Narcan counseling prescription. This was one big challenge. I'll show you guys what this data looked like. It was shocking to us how few patients were getting counseled and provided information on Narcan from their OB providers, mostly because OB providers told us they didn't know how to write the prescription and they didn't know it was their responsibility. Making sure that every patient is screened for hepatitis C. There's a lot of data, actually just some recent data come out again showing the high rate of hepatitis C for patients with opioid use disorder and substance use disorder. So important that every one of these patients gets screened for hep C. And then warm handoffs for MAT and recovery treatment services, close OB follow-up, and then provide patient education on OUD, NES, and then think really hard about how to help your providers reduce stigma and promote empathy across their clinical team. Next slide. So let me break this down for you guys a little bit and some of the tools and resources we use that are available in our ILPQC M&O toolkit. Anytime you guys can just pull up our ILPQC website and look for the initiatives and look under M&O, and all these information and resources are free and available for you guys. So universal screening for substance use disorder with a validated screening tool. This is recommended for all pregnant patients by ACOG, SMFM, ASAM. It's the standard of care. We talked a lot about this as a standard of care. U.S. Preventive Health Task Force also recommends this as standard of care. If people are using the old way of screening, do you smoke, do you drink, do you use drugs? That is not standard of care. And if you miss someone and they don't get linked to resources, you are not providing standard of care and you're not providing appropriate medical care. So that was a big argument that we used, particularly with our prenatal clinics, as to why they have to use validated screening. And certainly with our hospital teams, we were able to accomplish significant change in terms of having a validated screener for substance use disorder on every single labor and delivery now, pretty much in Illinois. We screen all pregnant women on entry into prenatal care and on admission to labor and delivery, and we document. It allows for the earliest possible intervention and referral to treatment. The goal of screening is to identify women with life-threatening illness, to start treatment early in pregnancy or before delivery discharge. The earlier we identify women with substance use disorder and get them linked in recovery treatment services, the more likely those women are to get into recovery and the more likely they are to be able to parent their baby. Certainly in Illinois, when we link women into recovery treatment services and they're in care and they're in treatment, they don't have DCFS cases open. They get support and continue to support in recovery, but those patients are much more likely able to parent their babies. And so the ability to identify moms with a validated screening tool, it's really important people realize these are self-reported screening tools. So these are looking for asking patients themselves and looking at risk factors for those patients based on what a patient is saying. It's not doing universal screening with urine tox. We use urine tox screening to follow women who screen positive, and we screen them with their consent to be able to show and demonstrate how they're doing with following their recovery plan. So the recovery treatment are the screening tools that we use most often in Illinois. The 5 Ps was the most commonly used. And then here on the left, I think this is it's the integrated health screening. So it basically has the 5 Ps in it. A lot of our hospitals like this one on the bottom right, because if you follow down, if someone answers yes, it tells providers and clinical teams exactly what to do with that information. So I'd say that's a very common one that was used. And then the NIDA quick screen was also used, but those are probably the 3 most common. 5 Ps by itself, the 5 Ps within this integrated screen, because it's really useful to help tell providers what to do, or the NIDA quick screen. Next slide. SBIRT. So again, you have to be really clear about what SBIRT is. We used a lot of examples of, like, if someone's screened for perinatal depression, the OB provider goes in and talks to them about a patient who's screened positive and figure out how that patient is doing. Are they ready to start treatment? What is the benefits of treatment? And make sure that that patient is connected to care. They don't see a positive screen and think, oh, someone 2 weeks from now should really talk to this patient about this. It's important for that OB provider to know that that patient screened positive and go in and have a conversation with that patient about this life-threatening medical condition this patient has. So I think that we tried really hard to talk to patients, to providers and teams about what this looks like. We gave them scripts about how do you do a brief intervention effectively. We did pocket cards. We put the SBIRT script on the back for people who started using paper screening in their outpatient sites. They would have the, like, integrated health screen with the 5 Ps on the front and on the back, and a place for the OB to sign it and put it into the, scan it into the chart. And on the back would have the exact, like, how do you do SBIRT? Here's your scale, you know, where are you on a scale of 1 to 10, ready to start treatment? So I think that the idea of teaching providers how to do this, what we say over and over again, this is what it means to be a doctor. When someone screens positive for a life-threatening condition, you go in and you talk to them and you figure out what the risk factors are. You try to make an assessment, and you talk to them about treatment, and then you link them to specialists who can continue to provide that care. So this became really important, that this was something that we taught that had to be done linked to the screening. And it's so important that this is done, particularly when you're moving validated screening out into prenatal offices. You need to equip those offices with what to do. The other thing we did, which I'll show you, is these M&O folders. That became really helpful because people are always scared to screen for something they don't know what to do when someone screens positive. So we made these M&O folders, and we put them in labor and deliveries across Illinois and prenatal offices across Illinois. So if someone screens positive, everyone's like, go grab the M&O folder. Here's the resource side and information for the OB and the nurses, what we need to do. Here's our checklist, here's all of our information. Here's the educational information to hand out to the patient. We also created this algorithm because it became really clear the OB providers did not know what their role was when someone screened positive for opiate use disorder. It was really this old way of thinking. They just thought, like, someone call social work and let neonatology know that this may be an opiate exposed newborn. So it became really clear we had to walk them through what optimal obstetric OUD care looks like. So just like we have an algorithm for severe hypertension, this is our algorithm for OUD clinical care. How do we provide optimal care? So you'll see if the patient screens positive for substance use disorder, opiate use disorder, if you go to the left, OB provider to see the patient, provide brief intervention to assess diagnosis, counsel on risks, and assess readiness for treatment. So we did very specific. This was our response to people being like, throwing up their hands to expert, being like, I couldn't possibly do that. I wasn't trained to do that in medical school. We're like, you were trained to be a doctor, so that is exactly what we're asking you to do. Go in and talk to the patient. And then below is how to link someone if they're ready to start. So a lot of them, example, fast track admit to the hospital for a fast track MAT start, or stabilize and discharge, and then stabilize and discharge to recovery treatment program, or initiate outpatient stabilization and a warm handoff to a behavioral health recovery treatment program. So really thinking very specifically about what we're asking folks to do. The far right-hand side is the OUD clinical care checklist, and all the things on that checklist that the team needs to do. Again, really emphasizing what does optimal OUD care look like, and that we are here to make sure that every patient who screens positive has optimal OUD care. And in the middle is just about billing and documenting. And then it was some of our Illinois hotlines. We had one hotline that you could call 24/7 to link OB providers to recovery treatment services in their area that they could link the patient to. And the other one was a warm line where you could call and speak to an addiction specialist to provide support for OB providers caring for pregnant or postpartum women with substance use disorder. And that was available on kind of Monday through Friday with a warm line where they would call you back. Next slide. So let's talk about creating the system. So I talked a little bit about this, but I think it became really clear to us that we had to help our clinical teams figure out how to provide optimal OUD care, that it wasn't happening on its own. And then also we have a lot of teams who felt like they didn't see many patients with opioid use disorder, substance use disorder. And so, gosh, it was hard to do it right when you don't do it very often. So this is where you really can dig into your quality improvement and put systems in place that get activated, that can happen every time, even if everybody who's there that day has never done it before. So let's go next slide. This is all about these resources to help our teams do it right. So this is what our teams came up with. All of these systems all came organically from our hospitals in Illinois who worked together to try to figure out the best ways to do this. So given the high risk of maternal death, we need systems to make sure that optimal OUD obstetric care is provided every patient every time. And these were the systems our teams came up with and really spread across the state. So the M&O folder, I can't remember which hospital started this, but I would say almost every hospital now in Illinois uses these. So it's basically a way to store in prenatal sites and L&D. On one half is everything that the providers, nurses need, and the other side are the patient education resources. So you've got your checklist, you've got your expert handout, you've got a handout on how to prescribe Narcan, you've got a handout to give the patient about how to use Narcan. You've got information about empowering patients around engaging in non-farm care. So there's all sorts of information there, but it allowed folks to just go grab that folder. We found that having a folder, actually a real folder, rather than just something that was available electronically, was actually much more practical in the clinical settings. Because what happens with something that you don't use very often is that if it is just somewhere on some website, no one remembers to go get that or where it is or how to get it. But if you have on the front desk in your place where you keep your handouts on perinatal depression, you also have folders that have big labels on them, say MNO. People know, oh, grab those, pink folders. We've got a patient who screens positive. Where are those folders? Oh, here's my information I need. So that became really helpful. And I think that was probably the most important thing our teams did. Prenatal care team conferences, this was a big deal. Our teams really moved toward having conferences when they identified a patient prenatally, where OB, MFM, neonatology, peds, social work, nursing would have a call to review the patient and to figure out an algorithm and make sure the patient had a plan. And then oftentimes nurses from labor and delivery or postpartum would call the patient, offer to give a hospital tour or talk them through what they would expect when they would come to the hospital. L&D care team huddles, this became a way to activate the MNO folders on labor and delivery. So using the huddle system, they added patients with substance use disorder, opioid use disorder, so that when they have the regular huddles on labor and delivery, any patient on the floor who had opiate use disorder had to be reviewed in the huddle. The MNO folder pulled out, make sure that the OB had the clinical care checklist, make sure that someone had been signed who is counseling this patient on Narcan, has this patient been linked to recovery treatment services before they go home, are they connected to MAT? So really reviewing the optimal care together on labor and delivery was a way to make sure that compliance was happening and to hold people accountable. A lot of teams developed OUD order sets. This was particularly helpful to make sure that Narcan order was prescribed, Hep C screen was done, and the appropriate consults happened. Next slide. This is an example of the MNO folder. So on the right side were the clinical team resources, the algorithm, the checklist, the Narcan materials, and workflow for nurses. And on the left is the patient education materials, which you guys can have access to through our website. Next slide. This is an example one of our teams sent us of their MNO folder that had, they even put more information in it. Next slide. The checklist, I'm not going to go through each of these elements, but this is the checklist, which is in the folder. Assess readiness for MAT, link to recovery treatment program, Narcan counseling prescription, a contraception counseling plan, Hep C screening, peds neo consult, social work consult, education provided, etc. So this goes through by trimester and during the delivery admission and then postpartum. And a lot of teams put these into their EMRs as well. Next slide. This is a nursing workflow for during the delivery admission. Teams really like this. Actually, we didn't have this initially, and some of the teams put this together and really called for it. And they said that their nurses need to know what their role is when they were admitting the patients. A lot of times the nurses were doing the validated screening tool. So the first page is the labor and delivery nurse, and the second page is the postpartum nurse. And it's just basically a workflow of things to check off that they've completed. And I'll let you guys look at that yourselves, but a lot of our teams really like this, and these were placed in the MNO folder. Next slide. The huddles, so missed opportunity reviews. Again, this is compliance monitoring. So a lot of our teams monthly or sometimes more would review if they had a patient with OUD. They would do missed opportunity reviews. This is a one-pager. They would look through the patient's chart and figure out if they missed anything with this patient and then give feedback to the clinical team. This is, I guess, how the huddle started, because there were teams who were doing this monthly. They would review if they had any patients with opioid use disorder. They would go through the checklist, go through the chart, and then they would provide the clinical team. And then they started saying, well, why aren't we doing this when the patient's still in the hospital? Because wouldn't it make more sense if we did this review of their chart while they were here, and then we got these things done before they left? So that's how the huddle started, was doing this missed opportunity review initially after the patient left to give feedback to say, hey, we'll do better next time. And then while the patient was still in the hospital to say, hey, let's check these things off and make sure we get these things done before the patient leaves. Next slide. These are those patient education materials I told you guys about that we created with patients' input. So really incredibly helpful. The top right one, I thought about this one when you mentioned that patients who had opioids prescribed hadn't had their providers talk to them about the dangers of opioids. In my practice, every single patient in our intake folder gets this upper right-hand one, prescription pain medication, opioids, and pregnancy, what every pregnant woman needs to know. So every single one of our patients gets that handout, but that's also in the MNO folder. And then there's things about, a lot of stuff about rooming in and non-farm care. Next slide. Counseling and prescribing naloxone Narcan is going to be a big emphasis for you guys, because it just is something that needs so much attention, because OB providers don't know how to prescribe this, don't realize that it's their job. And it's such an important opportunity when a woman comes through prenatal care and during that delivery admission to make sure that she has Narcan, that she's got some in her purse and her family has some. The Save a Life one is one that we made. It actually has the actual prescription, how to prescribe it on the flyer. That goes in the M&O folder or in the huddle, and it gets given to the OB provider to say, write this prescription. It even has a little QR code that you can scan that'll pull it up on your phone that says, here's how to write a prescription. And then the upper right is the quick start guide to give to your patients. Next slide. We, again, spent a ton of time providing resources for our teams, distribution, where to get opioids. We also asked our teams to put a pharmacy member on their QI team so that they could work on making sure that they had Narcan on their formularies, and also to add it to their med to bed program so that women could be given Narcan during their delivery admission and go home with it. A lot of emergency rooms are getting Narcan kits, and one of the big push in Illinois is to figure out if we can extend from having Narcan kits just given to emergency rooms, but also have Narcan kits available on labor and delivery so that they can be handed out if a patient has opioid use disorder. Next slide. These are posters we made that we plastered all over Illinois when we really realized we had to get OB providers to understand what they needed to do to save women's lives. We had to help them understand that this is the leading cause of maternal death in Illinois. So these flyers were kind of everywhere about what OB providers and clinical teams needed to do to understand that women are dying from opioid use disorder and that they are the ones who can prevent this. Next slide. And again, here's the Save a Life one on Narcan, and then the right one is about, left one's about screening. Next slide. Thank you. We spent a lot of time thinking about how to change thinking. And this is that I talked briefly about this, but the old way of thinking is we need to identify moms to help protect babies. The members of the healthcare team are the best people to provide care. The new way of thinking is we're identifying moms because they are at risk, and we need to get them into treatment and recovery treatment services early on. And we saw this again and again, where patients who previously, someone would just call DCFS and call neonatology and wash their hands of it, didn't think that there was anything they needed to do. When they engaged in our work, they say, oh, let's go talk to the patient. Maybe can we get her on MAT? We can start her on methadone during this admission. Has she gotten screened for Hep C? Has she been counseled on Narcan? Let's get her linked into a recovery treatment program before she goes home. Next slide. The stigma and bias is incredibly important. We worked a lot on this. The number one thing I'll say to you guys about, you can keep going through this, is the words matter. Right there on our website is a words matter module. So when you work with stigma and bias on your clinical teams, I encourage you to look at this words matter e-module that we developed around stigma and bias. A lot of teams have used that to good success. Next slide. ACOG, so we did a lot of training of buprenorphine training with our OB providers. We trained over 167 OB providers around the state. I think 45 of our hospitals had one of their OB providers trained. Next slide. And then here's our toolkit. Next slide. And then I'm going to go through our measures and then I'll be done. So you can go to the next slide. So we tracked monthly data. Our teams pulled data on every single patient with opioid use disorder who delivered at their unit. They also did a random sample of 10 charts per month to look specifically at whether women had documentation of screening with a validated screening tool prenatally or during the delivery admission. And our teams also reported on their structure measures. We simply used red, yellow, green. Red, I haven't started working on it. Yellow, we're working on it. And green, we're working on it. We had over 2,500 women with opioid use disorder have data submitted into our data set from our hospitals, about 71 women per month, and over 22,000 women in the random sample looking at screening. Next slide. These are our screening, our structure measures. I'm not going to go through every one, but you can see how initially everyone was red. Everyone was starting, they didn't have any of these things implemented. But by the end of the initiative, everyone had all of our systems changes implemented. So validated screening tool in place on labor and delivery, validated screening tool in place with your prenatal clinics, an expert protocol or algorithm on labor and delivery, the OUD clinical care checklist. You've mapped your community resources, so you know where to link women to when you screen positive, and then implemented standardized education. Next slide. The upper left is screening on labor and delivery. The green is with a validated screening tool. The yellow is the old way of screening with a single item to use drugs. and red is missed opportunities. So you can see when we started, only 2% of labor and deliveries had validated screening tools for substance use disorder in Illinois. We're now over 85%. This is, again, a random sample of charts. So over 85% of women, we've had 22,000 women in our sampling tool are screened when they come through labor and delivery with a validated screening tool. It's been a slower push on the outpatient side, but we're making progress. We've now balanced between 45 and 50% of women have documented screening with a validated screening tool prenatally, and we're continuing to work on that in Illinois. Next slide. So looking, the blue is linkage to medication-assisted treatment. When we started, only 41% of women with opioid use disorder were linked to MAT during pregnancy or before delivery discharge. And now we're up to about 75% of women in Illinois are linked prenatally or by delivery discharge. It's really important you track this data monthly and you're tracking this data for your hospital, because otherwise you do not know if you're providing optimal care for your patients or not. The orange is linkage to recovery treatment services. Again, less than 50% of women were linked to recovery treatment services prenatally or before delivery discharge. We made a huge push to say you cannot discharge patients with opioid use disorder unless they are connected to MAT if it's appropriate and linked to recovery treatment services. Next slide. Narcan counseling. This was just an incredible push. When we started, if you can believe this, only 2% of patients with a documented opioid use disorder on their problem list had been even counseled about Narcan or naloxone during their entire pregnancy and before delivery discharge, even though we know highest risk of death in someone with opioid use disorder is during that year postpartum. And only 2% had Narcan. So this is, you'll be shocked when you start to look at your data, how many of your OB clinical teams are counseling women on Narcan and documenting this. So we're pushing hard on this. We're going to be continuing to push on this year. We're up to almost 50% of our patients. Next slide. Looking at equity is really important. So we track our data by race and ethnicity as well. One thing we noted early on is that our Black patients had lower rates of being linked to MAT compared to our white patients. We've really closed that gap very purposely and strategically. So I encourage you to look at your data by race and ethnicity. Next slide. Almost done. This is our OB provider and nursing education. All of our teams track if their providers and nurses have gone through and completed e-modules and all the training, stigma, and I'll show you the resources we use. Next slide. Hep C screening also, it was rocky, but we've gotten there. Next slide. Same with prenatal, with patient education. Next slide. And then I'll go to the next slide because I know we're at time. Next slide. So these are the systems. I want you guys to really think about both systems and culture change as you're doing this work. We really worked hard on systems that helped our teams do the right thing for optimal care every time. The prenatal care conferences, the M&O folders, the labor and delivery huddles, and then that provider education is so important that they understand leading cause of death. What does optimal OUD care look like? How do we reduce stigma and promote empathy? And that we must take action to save lives. Next slide. I'm going to skip through this, but again, our teams are working hard, implement validated screening tools, activate them in a folder, and then confirm that optimal care is provided. Next slide. And then here are education tools. You guys can find these on our website, but we have the stigma and bias education. We have provider and RN e-modules, which was basically me in the middle of the pandemic, like strategies in my, literally in my bedroom in front of my closet doing these because they had to be filmed when we were in the middle of lockdown in April. Then we have our big campaign education flyers, and then we also have some simulation guides that our teams really liked using as well. Next slide. Almost done. So this is my last slide. So drug overdose, #1 cause of maternal death in Illinois, linking to MAT and recovery treatment services save lives, and that there are key steps your OB clinical teams must do. And your guys' responsibility as you start this initiative is to figure out how to put the systems changes in place and marry them up with culture change, and then track your data so that you can show that you've changed care for patients. So use systems like M&O folders or huddles or order sets to provide optimal care. Provide and document universal screening with validated tool prenatally and during the delivery admission. Counsel and assess readiness, linked to MAT and recovery treatment. Think about those warm handoffs. Initiate the OUD expert clinical algorithm, the clinical care checklist. Think hard about how you're going to work and move Narcan naloxone forward on your units. Educating moms. You don't realize how much moms get left out of this. I had many doctors and neonatologists tell me, oh, I never knew I should go talk to the mom. It always made me uncomfortable. I didn't want her to think I was judging her. So really thinking about how you educate moms and empower them to be a part of the conversation and really a part of the treatment plan for their babies, confirm warm handoffs, and then really actively work on reducing stigma. Thank you guys so much. I'm sorry I went a few minutes over, and I'm happy to take questions in the chat box.
Yeah, and we want to make sure that you have a few minutes to answer questions verbally, so we can go until, let's say, 1:24 with questions.
Okay.
And so if folks have some for Anne, please feel free. Let me call attention to a question that Allison asked earlier. Allison, you can ask it directly if you like, because I'm like scrolling up in the chat.
Sure. I completely agree that starting earlier than labor and delivery is most effective. How did you engage your prenatal clinics? And were you able to engage hospital-owned clinics as well as, independent clinics as well as hospital-owned clinics? And
so the way that we did it was completely through our hospital teams. And so that's why we're never as effective, and it's much harder to wrangle outpatient clinics, right? It's much easier to change systems and protocols during lead delivery admission. Our hospital teams, we created a whole packet. It was called our outpatient provider packets, or we created these packets that had emails that went out. Our teams, basically the QI team at the hospital, they went out and did meetings with all of their clinics that were affiliated with their hospital and brought out a packet. So they brought M&O folders, they brought the screening tools, and the M&O folders went over really well because it was basically like, here's your screening tool, here's how we're going to help you implement this, and then here's an M&O folder. As soon as someone screens positive, here's everything you need to know and what you're going to do, and then call us at the hospital and we'll set up a perinatal conference and link providers, OBs, and neonatologists and help you get the resources you need. So it was all based on the clinical team at the hospital. Some of our hospitals, it was amazing. I mean, they freed up social workers. There was a breastfeeding counselor who helped with this, nurses who went on the road and went out and visited their affiliated clinics. Sometimes they had to go multiple times. We had hospitals, teams that did tracked data specifically of their clinics and showed during grand rounds every week which clinics had what % of their patients getting screened. They had got their OB chairs involved, and the OB chairs putting pressure on the affiliated clinics to say, hey, this is standard of care. If you're going to be delivering at our hospital, we need you to be using validated screening tools. This is leading cause of maternal death in Illinois, and we have to be providing standard of care. So lots of pressure from OB chairs, collecting data to show clinics how they compared to each other and sharing that publicly at grand rounds. And then a lot of really awesome nurses who went on the road and went out and visited all the clinics affiliated with their hospital and shared with them the packet. And then we provided a lot of resources to try to make it as easy as possible. But we at the collaborative, it was all the hospital teams who were helping to engage their outpatient sites. And so you can see, like with prenatal screening, we were at 85–90% of women getting screened with a validated screening tool when they came in for delivery admission, and we were about 45–50%. So it definitely lags behind because you can't make and corral every outpatient site, but we did a pretty good job. And I think that this was totally the fact that we had these awesome QI teams that were so motivated to get these patients identified prenatally and get this information out to prenatal providers. Other questions?
And Dr. Borders, hello, Jamie Cabrera, good to see you again. I just wanted to add for our group here today that that's something we've been discussing too with like even the hospital association and other partners, how we can support the hospitals from the collaborative perspective of making that map of community resources, engaging the providers that refer patients there for delivery, and really connect those dots, because I agree with you. It's like, it's a starting point, to screen on admission for delivery, but there's all that opportunity before.
Oh, absolutely. So that's why our teams worked so hard. And that's why those prenatal care conferences were so often, because it really showed this great collaboration between the outpatient and the inpatient. And it really helped the outpatient providers who felt like, oh my God, I have no idea what I'm supposed to be doing here, feel supported. Hey, you're going to have an MFM who's going to do a consult. We've got neonatology or peds who's going to consult with you. Our nurses from labor and delivery or postpartum are going to be on and talk to they're going to call your patient and give them reassurance that we have an advocate. We had one hospital who every time they identified someone prenatally, one of their nurses like went out and tried to meet with the patient out at the offsite, like really a lot of like, we're going to be your advocates. We're on your team. When you come to the hospital, I know you think everyone's going to be judging you, but we're here to support you.
Yeah.
Lot of figuring out how to be super supportive of these moms and help create this team atmosphere, that you've got this team that's rooting for you and that we're going to be here to help you get through this. So I felt like our hospital teams just did an amazing job of centering it at the hospital, because that's where collaborative is centered and where we had our QI team, and then working really hard to figure out how to engage their outpatient providers, because of course we need to identify these moms prenatally and get them into treatment and recovery treatment services and support them prenatally so that they can be on the road to recovery before they show up at the hospital. The hospital is the last gap stop, right? If someone hasn't gotten the care they needed or they didn't get prenatal care, we want to make sure that those moms do not go home from that clinical, they've been in the hospital. It's a perfect opportunity. Really quickly, I had a set of residents call me. It was Memorial Day weekend, right after we'd started our initiative. I'd given a grand rounds to this community hospital and to the residents about this work. And then they had my cell phone somehow. I was not on, I don't even know how they got my cell phone, but one of the residents got my cell phone. I'm trying to drop off kids at gymnastics. I'm driving carpool. They call me and say, Dr. Borders, it's 7 o'clock Memorial Day weekend, Friday night. We've got this patient we're trying to discharge, but I remember you said we're supposed to do something for women with opioid disorder before we send them home. Can you help us? I said, okay, do you have the checklist? Do you have the algorithm? Go to our website. Let's pull it up. What have you done for her? Well, she delivered on Wednesday. We know she's had a urine tox screen positive for opioids. The baby has got NAS. It's in the NICU. What have you done? Well, we called social work. Can you read the social work note to me? The only thing the social work talked about was DCFS and that your baby is getting taken away. There was no mention of her opioid use disorder, linking her to services, what she needed. It was all focused on the baby. Neonatology had taken over the care of the baby. Has anyone talked to the mom about her opioid use disorder? No, no one's mentioned it to her. And we're getting ready to send her home. So I said, take this tool, go find your attending, read it, and then go talk to the patient and call me back. Went to talk to the patient. Patient had been on MAT previously, had relapsed during the pregnancy, was at her bottom, knew the baby was getting removed from her care, was desperate to get on MAT, didn't want to mention it during the hospitalization because she was afraid if she brought it up, it would make it worse for her keeping her baby. They screened her for Hep C, she was positive. It was Friday night. They got someone to help them start her on methadone. Patient stayed through the weekend. They kept her for the 3-day weekend. And then on Tuesday, they got her into an inpatient recovery treatment program with treatment for her Hep C, with a Narcan prescription, into recovery treatment on methadone. And then they called me back later and said, we just had no idea that there was a set of care that we were supposed to be providing for the patient. We weren't thinking of her as the one at risk of death. We were thinking of the baby as the one with the issue. And so I tell that story a lot because it just really shows like, these are women coming in desperate situations, and often their care team is just in total disconnect and doesn't realize that they're supposed to be providing optimal care for a woman who's at great risk of going home and dying on her bathroom floor.
Yeah, thank you so much for sharing that story. That's an amazing note to wrap on, and such a good illustration of what.
Well, we are happy to help in any way, guys. I really encourage you to be very intentional, have very focused strategies, know exactly what you're asking your teams to do. Think about how your data will help. Until our team started collecting data on Narcan, MAT, linkage recovery treatment services, they had no idea if they were providing optimal care or not, and they really valued that data. Think about putting systems in place, because unless you have systems to make sure that optimal care happens, it just won't happen for any random given patient. So good luck, guys, and let us know how we can be helpful. And please feel free to use our resources.
Thank you so much, Dr. Borders.
Okay, bye, guys. Happy Valentine's Day and stay safe.
You too. Thank you.
Okay, I'm going to head out. Okay, bye, Katie.
Bye. And if anybody has any additional questions for Dr. Borders, we can collect those and follow up with them after.
Just send them to me. I'm happy to do it. I'm on call this weekend, but happy to answer questions. Bye, guys.
Okay, so I just want to double check. I apologize for my voice. I have a bit of laryngitis this week. Can I get a yes that you can hear and understand me?
Yes.
Okay, great. Sounds good. So that was, I always love hearing Dr. Borders talk about the great work they've done in Illinois and seeing the progression of how far they've come. And I'm really excited to see these teams work through this work with us as well. I do want to just make an additional note about the idea of prenatal care clinics. We kind of talked about this prior to the Learning Collaborative, and recognizing that we are not stopping at the labor and delivery unit, we're starting at the labor and delivery unit. And throughout this whole process, throughout this year, we're going to be trying to work with your teams to do that further upstream work, and also looking very closely to the Chosen Quick project, which is piloting moving into the prenatal care sites for a lot of this substance use work. I will also note that Dr. Borders shared some fantastic resources for us, and you will recognize a lot of those resources in what I'm about to share for you. So we kind of have a policy in the perinatal quality collaborative world of steal shamelessly. So there's a lot of great information and resources out there, and part of our job here is to help connect you with that information. Okay, so what is next for us? So as Katie mentioned in the beginning, what we're really talking about today is making sure that you feel prepared to start the pre-work and be ready to jump in with us during the learning session. So I'm going to walk through, there's 3 major resources that we're going to share with you today, and then I'll walk through your pre-work documents as well. So the first thing I want to say, Katie did a brief overview of the model for improvement. The documents that I'm sharing today are going to help walk your team through thinking of how to answer these questions. So we've kind of thought about this at the collaborative level, but then we're also asking your teams to take those goals and the collaborative plan and really drill down and think about what is our team going to accomplish this year and how are we going to make sure that we're having an improvement. Okay, so strap in, we're going for a ride through these resources. So first off, I want to share our project guide. As Katie mentioned, there's a lot of terms that I'm going to throw around. You don't have to memorize them all. We tried to specify here what each item is. And it should become clear as you go through the collaborative and start looking at the documents. So the project guide is really the one-stop shop for all of your hospital champions to go through the checklist of how do we participate in this learning collaborative. So it outlines your steps for getting started. It links to templates for completing your pre-work, and there are checklists that walk through what needs to be done, when it needs to be done, and how it needs to be done for each project period. So we tried to break it up as clearly as possible. This document also includes that table of all of your key dates with the registration links. And it also includes kind of a project overview in case you need to share any information with your administration or somebody else. So how should you use it? Read it, print it, forward it if it's helpful. Really going through and reviewing those checklists to get kind of a high level view of what's coming for this year. So let's take a quick look at that project guide together. So you'll see this is all linked on our Google Drive in the Team Resources folder, which I will show you shortly, but we'll also send out the link separately. So you'll see the table of contents. It's a fairly large document, but that's because we included the actual templates for what you're going to be completing. And it's mostly one-page checklists, so it lengthens it a little bit. You'll see in the beginning, we have the key dates, the project overview, and the key drivers. So if somebody is not sure, you know, what is this project about and what time commitment and all of that, these are kind of the areas where you're going to look. We outline those expectations that Katie already walked through. There's a sample data use agreement and a checklist for what needs to be done to complete the data use agreement. And then there's more information on data and reporting. Then we also have the last 4 attachments are really about, those are checklists that walk you through how to do each of those pre-work things. And I'm not gonna go to those right now because I'll go through them in a few minutes. but just to see how it's organized. It is really, how do I get started? How do I put my team together? Really, for this, start on page 3. Between now and April 2nd, here's what I need to do. It looks like a long list. A lot of you have already done most of this. So there's a few key things, for example, doing the process flow and the other documents. Okay. And then there's just a brief overview. This is great for sharing if you have anybody in your administration, or if you're even curious about what are we going to be talking about this year. So we kind of have a brief content outline. So what topics are we going to cover? And if you look at this list and see something that's not addressed, feel free to reach out to us and say, hey, my team really needs help with this. Can we do an informational call on this? And we'll be covering these topics both between the learning sessions as well as those monthly coaching calls in between. Before I jump from the project guide, does anybody have any initial questions? Next up is going to be your change package. So a change package is really part of the IHI Breakthrough Series model that is the evidence-based set of changes that are critical to achieving improvement of an identified care process. So what are the elements that really need to happen to drive improvement in this area? And included in there are resources to help you apply those changes. So what we've done with this change package is we've pared it down to really focus on what we're emphasizing this year, which is implementation of those best practice protocols and making sure that your hospital is able to respond to substance use disorder at all of those levels of the AIM bundle. So that's readiness, recognition, response, referral to treatment, reporting and systems learning, and then lastly, respectful care. So ensuring that stigma and bias, patient-centered care, and trauma-informed care are really incorporated throughout. How should you use it? Read it, print it, save it, forward it to members of your team. So this is going to be a really useful document to help walk you through, okay, we know what the key drivers are. Let's dive deeper. What's the best practice justification? What are the links to the ACOG committee statements and the SMFM statements and the literature that supports this as a best practice? And what are the tools and resources that we have access to help us actually accomplish these? So we link numerous resources throughout. We in no way link everything that is in the resource folder, but we call out specific things that are particularly helpful. One thing that you should do is, as you go through this change package, discuss with your teams how you might want to implement the changes described. So the best practices are going to be the same across the board, but they're going to be applied differently. So really thinking about what is our workflow, what is our process, what needs to happen within our facility to make sure that we can implement this adequately. We'll take a quick look at the change package. I love seeing the anonymous animals. So welcome to the change package with me, everybody. So as you can see, there's a table of contents. We do a brief overview of the project goals and key drivers just to reframe what this is about. And then we have the change concepts organized by each section of the key driver diagram. So for example, under readiness, we're going to go through and we're going to pause briefly at the key drivers. So under readiness, we know that we want to develop and disseminate protocols. We want to create community resource maps, and we want to do training and education to promote understanding of substance use disorder as a chronic disease, and then build around that understanding the common comorbidities, how stigma and bias and environmental and social factors influence this disease. So in the readiness section, you will see develop and disseminate protocols, but then there's more detail within that. So universal screening, why are we talking about universal screening with a validated tool as a best practice? what are the best practices for in-hospital treatment of substance use disorder? What are the best practices for pain management? And we also include here not only the best practices, but we have sample protocols from other hospitals across the country who already have implemented these protocols. And then there are specific protocols for patients with substance use disorder or opioid use disorder. So I do want to make a note about that. Dr. Borders just presented on opioid use disorder. So their implementation of the AIM bundle was explicitly focused on opioids. We do know that in the state of Colorado, we have ever increasing rates of methamphetamine use as well as a significant rate of co-occurrence of substance use. And so we found it very important throughout this entire process to focus on substance use overall. So identifying tools that ask about more than opioid use disorder, things like that. That said, there are many things that are specific to opioid use disorder, such as the medication-assisted treatment for opioid, or apologies, MOUD, or medications for opioid use disorder. And so we will do our best to call that out whenever there's something that's unique to OUD. But if you ever have a question, please just ask. And then we have some patient education materials. So from Illinois and Utah, there are shared decision-making guides, conversation guides, things like that. And then ensuring that we're setting up adequate outpatient referrals. So each section takes every change concept, which are these bullets, and really broadens it out and provides additional resources. You'll see in here that we have a clinical care pathway template for us to start working off of as we go through this project. This might look very familiar because Dr. Borders just shared essentially the same flow, it just looked a little different. And we have the clinical care checklist that she referenced, which does include antepartum and third trimester care, bringing into focus, of course, the birth admission checklist. So really thinking about, are we accomplishing all of these things in our response to opioid use or substance use disorder? We also have, we talked about recommendations for screening tools to use. Dr. Borders shared a few additional ones that you're welcome to check out. But we identified just these two brief screens, and we also talked through why we selected these for potential use, particularly focused on the state of Colorado because of that legalized marijuana. And then the emphasis on prescribed substances as an exposure, because we don't only want to know if a patient is using illicit substances, we also want to be capturing and ensuring optimal care for patients who are already in treatment and maybe only exposed to a prescribed opioid, for example. And then we also list out some important considerations that may help you decide whether or not this is an appropriate tool for use on your team. Okay. The team resources folder is the last resource I'm going to show you. Essentially, this will turn into that paper folder for your teams, and also will become our project website, which is still in development. We just wanted to make sure that you had access to these resources from the get-go. So bookmark this folder. This will be a really great place to go to. And then ultimately, you can replace that bookmark with our webpage. Please know that we're always adding resources to this. It is not a final document, but you can explore the folders to find tools, referral sources, templates, education tools, etc. If you're looking for something specific and can't find it, let us know. We'll either help navigate you to it or we will make sure we add something in there. And this is a great resource to share with everybody on your staff. So just to show you what it looks like, it is simply just a Google Drive organized by type of resource. You'll also see that there's a change package folder and a project guide. So if you're looking for either of those are right there. And within the change package folder, you'll see the sample screening tools, you'll see the AIM OUD bundle, you will see your data collection sheets and you'll see those checklists and sample pathways. Okay. Any questions about those before I move on? Okay. Now, for the pre-work. Again, what are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in improvement? So all of your pre-work documents, which are listed right here, are going to help your team answer and be prepared to do the work of solving those questions. So first, we have a project charter. So the project charter provides a rationale and roadmap for your improvement work that can be used to clarify how you think about what needs to be done and why. So it will help you focus your opportunities to address the specific problem, specify who on the care team is a member of the improvement team and how they're going to be engaged in this work, and really answering those questions. So the link here takes you directly to, again, this is in the team resources folder. IHI has a very handy project charter template with instructions on how to fill it out. So this will be your resource for completing that part of the pre-work. Next, we will ask your team to tell your story. Who are you? What are you currently doing? What are your current challenges? And what are your aspirations for this year? So what do you want to achieve in this project? So really identifying the strengths and expertise of what you have on staff, and then how you can leverage that expertise to make positive change. And then we are going to ask your teams to briefly share your storyboard at learning session 1. So we do want these completed before learning session 1. So I'll just quickly take you to the storyboard. This is a PowerPoint template with instructions for how to fill out each section of the storyboard. And I'll talk about process flow in a moment, so I'm just going to leave this up. Next, we're going to ask your team to put together a 30, 60, 90 plan, and you will see that this is a common, I personally think your 30, 60, 90 plan will be your best friend throughout this whole collaborative. So you will be using this to say, what are we doing this month? What are we trying to accomplish in the next 3 months? So that you're really walking through and keeping up with what you're accomplishing, what your next goals are, what your challenges are, and how to move forward. So again, we have a template in the team resource folder. You'll notice the logo on the upper right. This was shamelessly stolen from Illinois. But essentially it just walks through what are we trying to accomplish, how we're going to do it, and who's going to be responsible for doing the how. And then lastly, we'll ask you to complete a process flow diagram, which really describes your unit's process for identification of and care of delivering patients affected by substance use disorder. So this is going to be a work in progress. It is going to change throughout as you implement your improvements. But this, what we're asking you to do for the pre-work period is really saying, where are we now? So again, in your storyboard, which is where you'll complete this, there are instructions for your process flow mapping. And then there's a template for you to fill out. Lastly, we have a few data tasks for you. So I did not send these to every single member of your project team. So if you aren't sure if you got it and just want to check, please feel free to send an email to info@cpcqc.org just to check in. But last night I sent the data use agreements to all of the project teams, and we're going to ask you to please review that and forward it to the appropriate parties by next Friday, so that we can start the process of getting those signatures so that when it comes time to report your data, you're able to. For this project, Dr. Borders talked a lot about the importance of, we don't know if we're making an improvement and if we're actually following our protocol unless we're collecting the data. For this project, we've done a lot of back and forth and had a lot of input from our expert faculty group, from our quality improvement partners, as well as some of the participating hospital teams. And we've decided that for this project, we're going to have a single one-page monthly data collection sheet that's required. I'll show you this now. This really asks those questions of, do we have the guidelines and protocols in place? Is our structure built out to achieve these improvements? And so what we're focusing on this collaborative is doing the education and the background work and the structural work to allow you to improve care for patients with substance use disorder. And then each month we'll also just check in with you about any challenges or successes that you've had, and then an update on your 30, 60, 90 plan. Optionally, particularly for hospitals that are further ahead in this work, we have a patient data sheet that can be collected for every patient identified with substance use using that brief screen. I'm going to show you this, but I'm not going to spend a lot of time on it. And we're also providing this because even if your team is not reporting this as part of the project, this is a model for this is where we're going. So as we go through and we look at our EMRs, as we go through and we're talking about going through those checklists to make sure that we are providing that optimal care for the patient, this data sheet will help us track and see as we implement something, how are we doing in our process of actually following through and activating that protocol. So we're not going to require that data, but we are providing this data sheet to allow your team, and we will also, if your team decides to collect and report any of that data, we'll also help you analyze and break down and problem solve around those outcomes. Again, refer to attachment 6 of your project guide with more information about the data collection, including when it's due, how to report it, things like that. Lastly, I'm going to ask you all to identify your team's data lead. You can have multiple people enter data into the system. Just send me the email addresses and full names of everybody you want to have access to REDCap. We'll then go through and set up those accounts and then do a training for those individual data reporters. So as a recap, here's your pre-work checklist. This is what you're working on between now and April 2nd. And we've put some internal due dates in there between now and April 2nd just to help your team really kind of move through the process and not be scrambling the day before this first learning session. Okay, so Megan, I'm going to ask you to please bring up the evaluation poll. And so we have about 9 minutes left. So I want to welcome any questions, thoughts, or even just emotions that you might be feeling about this. Are you excited? Are you nervous as a part of this project? Do you have new thoughts about how you'd like to engage with this work? And you'll notice that every time we do a learning session or a coaching call or anything like that, we'll pull up a similar evaluation poll. One thing I forgot to mention is we do quality improvement work, which means we are ever working on our own internal process as well. So we openly welcome feedback, both through these meeting evaluations, but also if you're more than welcome to just send us an email if you have questions or concerns, or if you'd like to see something different. So with that, I'm gonna jump over to the chat and see if I missed any questions. And team, if there are any questions I missed, feel free to.
Well, it looks like someone from UC Health North, they're asking if anyone's on there, and if so, let's connect. I think that's a great idea. I love that, is helping to connect hospitals, right? Whether you're in the same health system or even outside. We've had a lot of great collaboration with, I think I saw Courtney's name here, Courtney Cryer from Montrose, and others from Vail, or other hospitals that are, you know, in similar regions or of similar size. So don't be shy. Yeah, send in your info, and that's one thing I think that will be really helpful in the webinars and the learning period sessions when we get everybody together, is getting to know people from your health system that are outside your hospital, and certainly from other hospitals across the state that might have some relatable experiences that we can learn from each other. So don't be shy, throw your info in there, and let's help people connect.
Absolutely.
We might
All right.
also, we can pull up the previous slide with the checklist, and if you have any questions on the pre-work or the deadlines, you know, we can keep this up just in case, but
Or if they
please
shared
do, if
anything that you
don't
would
have
like.
any, sorry. I was gonna say, please do, if you don't have any questions, like Val said, please do fill out that poll that should be up right now, because that'll really help us.
I was also going to say, please feel free if you'd like to take another look at any of the resources I pulled up. I'm more than happy to pull them back. So, and with that, we're coming up on 2 o'clock. So I want to thank you all so much for your time. I know this was a lot of information. We are so excited to have you joining us in this work, and we can't wait to get started. So thank you.
And we'll keep this, you know, keep everything up until 2. And, you know, I'm still responding to some DMs in the chat. So thank you.
Awesome. And our team will get out all the links, links to drives, links to packets, all that fun stuff. And we are here to handhold. So don't be shy about asking for help. It's a ton of information and a lot of work.
Okay, I'm going to go ahead and close the poll.
Thanks, Val. We do have a question that just came in about a link to the recording.
Yep. We will be sending out the link to the recording and the link to the slides, and all of the documents that we mentioned today. They'll all be in the recap, and you can definitely forward them to whoever you want. And yeah, you'll have everything you need.
And I think we can put that, the recording and slides directly into the team resources folder, so you don't have to dig somewhere else for it.
Perfect.
And I think, team, our goal is to get stuff up on the website eventually too. So and people who aren't participating and don't have a team folder can also access this great information. So great. Awesome.
And for the folks, you know, like Christina, or who is in Arizona, or other people, you don't need to worry about the fact that you're in a different state at this time. We will worry about that for you and figure out what it means for data reporting. And we've already initiated a conversation with AIM National to help figure that out. And we've talked to the Arizona Hospital Association and their PQC and AIM people. So don't worry about that on your end. We'll totally take care of it. And we just want you to participate and not worry about the fact that we're in a different state.
I have a private message in the chat asking how this work will align with the chosen work. So I'm really glad that you asked, because I didn't go into detail on that. So if you look at the AIM bundle itself, there are many more best practice care elements than what we included in our key driver diagram. So the chosen project has really historically been focused on substance exposed newborns. So in the neonatal NICU. And this project is really focused on adding in those maternal care elements. And so as we move closer and begin to collaborate on this work, really bringing together the OB teams and the neonatal teams. So throughout this project, for all of the hospitals that are doing both initiatives, really encouraging that increased coordination between the obstetric care team and the pediatric team. And so we're still working through on the back end with the chosen teams, and so more to come later. but we're really trying to align wherever possible, even down to the level of data collection. So that's kind of a vague high-level answer, but we're really focusing on how can we marry these two projects so that we can focus on the mother-infant dyad and provide that optimal care for both. And Jamie, I know you've been doing some background work as well. I didn't.
No, you got it. That's exactly it. We're really closely partnering with Illuminate and University and all the great work that's happening already with the Substance Exposed Newborn Steering Committee, and looking to really leverage that work in our work as well, to consistently align those efforts, and then to Val, to your point, really connect a lot of the prenatal conversations that have started taking place with chosen quick hospitals too. So it's a great opportunity for us to continue to collaborate and expand this effort.
Yes.
Right, looks like we're at 1 minute. I bet people are anxious to get started with their weekend, or maybe unfortunately their next meeting, right? Thank you, everyone. Greatly appreciate your participation and leading this work in our state. It's going to be a lot of work, but really important, critical work. So thank you all.